Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins.
Welcome back to the Dusty Muffins podcast. Today's episode is what are the menopausal hormone therapy medication options? We're diving into the different medication options available for menopausal hormone therapy. We'll break down the types, how they work, and what to consider when discussing them with your doctor. I'm Aoife O'Sullivan, a family medicine physician over in Oregon and a Menopause Society certified practitioner.
Hi, I'm Dr. Christine Hart Kress. I am a board-certified women's health nurse practitioner and Menopause Society menopause practitioner over here in Virginia.
Hi, I'm Dr. Rebbecca Hertel. I am a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner, and I'm in Pennsylvania.
Awesome.
Hey, we're a little crazy today.
It's good to see you all. We've been on text messaging. And just for the listeners, if you could have been here to watch the theatrics of both Rebbecca starting with having a hot flash and having to remove her socks, which then sent Aoife into her hot flash. And they're both sitting here fanning themselves. And our tech support, fabuloso Aaron is probably like, what the hell is going on around here? Because it's a hot mess rolling up in here.
Yeah. Yes. And this is what happens even behind the scenes. Remember, we're going through all of this with you. And so as we're literally telling you, I'm going to tell you about all the medications, I'm thinking like, do I need mine increase? Because I can't think. My words are like stuck and I'm hot as hell. So.
As a certified menopause practitioner, I think that answer is yes from just the 3 minutes of observation and the weekend of crazy text messages.
And I'm going to have to invest in a lovely fan. So when you see us on YouTube, I'm not with my pad.
Yeah. Here.
All right.
All right, my darlings. Where would we all want to start on this lovely little journey of what medications we use to treat these fun little symptoms?
What menopausal hormone therapy is?
I love it.
So it's called different things, right? So when someone has premature ovarian insufficiency, which is when you have your last period before the age of 40, or early menopause, when you have your last period before the age of 45, we call it hormone replacement therapy because we are truly replacing something that your body really, really needs. And we're replacing it in proper, large enough doses. But then when you go into perimenopause and then after your last period, when you're menopausal, we call it menopausal hormone therapy because we're using much smaller doses, right?
Yep. So most people will say, oh, it's hormone replacement. And really that we're really trying to transition all clinicians and just the buzzword away from that. Like Dr. O'Sullivan said, to menopausal hormone therapy and not hormone replacement therapy, because it really is two different things.
And I think too, it's important for women to know that the highest dose of menopausal hormone therapy that we use, that estradiol, is lower than the lowest dose of birth control pills. And I've heard it said a couple different ways that, the menopausal hormone therapy that we prescribe on average is 1/4 of one pill in a pill pack. I've heard other people say that it's 1/10. I've never personally, done the math on it, but it is such a low amount. And so lots of women are on birth control pills for years and years and don't blink an eye at the amount amount of estrogen, and that's synthetic estrogen, ethinyl estradiol. And the amount we're giving you in hormone therapy is just the amount to gap what the receptors from head to toe are looking for, so that we can put some estradiol on those receptors and knock out the symptoms that you're having.
Yeah, we're trying to, sorry, Rebbecca, we're trying to get your estrogen level above your husband's.
Yes. Wouldn't that be nice? Because you know, when we sit here and we talk with women and we're like, listen, your husband right there next to you, if you are a female and male partner, you have none and he's got more than you. Yeah. Like forever. Yeah. And they're like, and the husband's like, I'm like, yes, honey, you do. You know what I like to do with my patients? And I don't know if it's good or bad. I like to use my hand. Mm-hmm. So I'm like, okay, if this is 0, then menopausal keeps you like here at like 50. Your birth control's here at like 100, 150. And then being pregnant is like up here, right? Or up and over. Mm-hmm. And sometimes that kind of gives them at least a little graphic visualization when I'm like, okay, it's a tick here, then it's here, and then it's here. And it just seems to kind of help.
I like that. Yeah. I have not seen that in education, but I'm always looking for something like that when I'm educating women, because I think it's really helpful to see something, a graph, a step.
Yeah, it kind of gives them
something to compare to. Mm-hmm. That's awesome. Yep. I will be using that this week in seeing patients. So thank you, Rebbecca.
You are very welcome. This is called a collaboration, in case anybody wonders. Like we collaborate all the time at all these little ideas. Remember, 3 brains are always better than 1, especially when they're perimenopausal and menopausal. Because maybe some estrogen receptors are more bound in one of us than the other.
I feel like between the 3 of us, we've one really highly functioning brain.
Oh, 100%. It's a pretty kick-ass brain.
So menopausal hormone therapy. So is FDA approved for hot flashes, night sweats, vaginal dryness, and the prevention of osteoporosis. But you don't have to have one of those things in order to gain access. We will use I will use menopausal hormone therapy. I mean, usually everybody's got at least one symptom. I mean, most vaginas are dry.
You really ask the question, right?
Right.
Yeah.
But, really, we know that, it'll help with the ringing in the ears, the heart palpitations, the burning tongue, sleep, mood. Is that the primary reason why we're using it? No. But do we know that when you're lacking those hormones, you have those symptoms? Yes. And, there should not be in 2025 a gateway of you have to have one of those things. And everybody needs to have prevention of osteoporosis. Everybody. Right. Estrogen is the only thing that's going to keep your bones together, unless you're just really lucky. But, most women will have some bone loss by the time, their average life expectancy for women now is, I think they're saying 82. You're going to have bone loss. That's inevitable to at least have 30% bone loss by the time you're 80, even with good genetics.
And oh, sorry. Go ahead, Rebbecca.
No, I was just going to say, and it's okay to say to these women too, like, okay, so it's FDA approved for this, and we technically use it off label for this, just so there's not any confusion. But it doesn't mean that we use it all the time, because there, for brain fog and whatnot. It just means that it was studied here, and we know this. But off label, just like we use so many other things off label as well,
like birth control pills,
right? Go ahead.
Yeah.
Go ahead, Abe.
Oh, well, I was going to make kind of the same point. Like being in primary care, you take care of everything. And so it's really obvious to me how differently we treat women's midlife healthcare. Because when I am using psychiatric medications for cardiology meds, pulmonary meds, I don't sit down and say to a patient, now, this is not FDA approved for this, but we use it all the time. I mean, I just go ahead and treat, and that's what specialists do too. They don't sit down and go back 20 years and explain the studies that were done on this,
That's a good point.
Or
That's
when
a good point. We don't.
like you said with the pill, like the pill is not FDA approved for acne or menstrual cramps, and yet we throw women on it all the time, and we don't say, now this is not FDA approved for menstrual cramps, so here, sign this consent form because it's not FDA. No, we don't do that. That's ridiculous.
You're right.
Right.
It's
Or
absurd.
suppressing your cycles, which
Exactly.
everybody's up on skipping some cycles in a year.
You're right. We don't even think about it twice. I don't think twice about it. You're right. You know,
it's very expensive to get FDA approval. And so drug companies pick and choose what they will get FDA approval for, things that will be really obviously fixed by their medication. And they get FDA approval for that. And we use medications off label all the time. Off label is when you're not using it for that FDA approved indication, like the pill for acne.
Still means it's safe. It doesn't mean that it's not safe. That's a big distinction I think we need to make. It doesn't mean that it's not safe. So
exactly. Yeah. And I think, for some reason, clinicians have clung on to these FDA approvals for hormones, like they're clinging on to something for dear life. I don't understand it. It's like, it's FDA approved for these conditions if they're extremely severe. Like, who am I to say my patient hot flashes are severe or not?
It's not it's not our place to judge too many, too often, because like one of the things that I've been hearing this week when I've been talking about hot flashes, especially women who wake up in the middle of the night, they'll say, oh, I don't have night sweats. And I say, okay, explain that to me. They're like, well, I'm not waking up in a pool of sweat. And, even when I have my hot flashes, it's not the movies where I get red and start dripping.
Yes.
And I'm like, well, you don't have to, like, that is just
it's not that bad.
No,
that's what they say, right? It's not that bad.
Exactly. It's
well,
okay.
Do you know? It still makes changes in your brain and it still affects your heart, honey.
Yes.
Right. And it doesn't have to be that. And I think you're right to that point. We've made it seem that you have to be drenched in sweat and, and steam coming off your head and in a pool of sweat at night to where you're not sure what happened to you in order to seek treatment. And I think that is so unfair because what I just had was really uncomfortable. And when you have that happen multiple times during the day, or not even multiple times, or just throughout your day, that was very disruptive,
Yes.
Like it's very disruptive. And then I'm not thinking and I'm not focused on what I'm doing. And so that not that bad is a way for women to say it like, well, it's not that bad. I'm okay.
Even one is one too
Even
many.
one.
Yeah. I just made a note there for an episode idea. So we'll go into vasomotor symptoms someday soon.
Yes. Yeah, we will.
In
talk
depth.
about that.
Yeah. So let's move on to the types of hormone therapy. Let's talk about who could use estrogen alone and why we might do that.
You're quizzing us, Aoife?
No, just throwing out ideas.
So, yes, I like that. So go ahead, see. So estrogen alone would be a woman who either has an IUD for uterine protection or a woman who does not have a uterus.
Yeah, because we're using progesterone usually because estrogen is such a good growth factor. It helps everything grow, which is wonderful. But if you make the lining of the womb, the uterus grow too much, that can actually be a problem. You can get a thing called uterine hyperplasia, which down the line can sometimes increase your risk of uterine cancer. So we don't want to go there. So that's why we give women with a uterus progesterone. It's not the only reason. But definitely, if you have a uterus, you're going to get progesterone in some form, whether it be a tablet or the IUD.
Yep. Or a combined patch.
So I think we probably all kind of have our favorites of how we prescribe, right? I tend to prescribe a lot more gel, estradiol gel, for the simple fact that I like estradiol. Because it doesn't matter what I like, it matters what the patients want. I do present all of the options, but one of the things that I find really helpful of estradiol gel, because you're applying it every 24 hours, you get really nice steady states. You apply it to your inner thigh or the top of your thigh, is where I tell my patients to apply it. I have them do it at night because I find it covers night sweats really, really well and helps tremendously with sleep. I also like to do it. It comes in little packets. And, you know, sometimes, especially in perimenopausal women right before or during their cycle, when their estrogen levels are particularly low, you might need just a little bit more. And so, you know, I will tell my patients, you know, you can use 1.5 of these or 1.25 in someone who's perimenopausal. We don't need to worry because they're making their progesterone and they're probably already on a progesterone, but I don't have to worry about them taking more than 1 milligram of estradiol, which then requires more progesterone if you are menopausal. So this is the one that I think I probably prescribe the most, or that people switch to eventually. The only thing that's kind of a nuisance about it is that it does take, especially when you have, you know, a standard dose would be 0.5 milligrams. So when you have like 0.75 or 1 milligram, it's a lot of volume in these little packets. And so it takes a long time to dry. And so that's the other reason why I like it at night, because inevitably, if you're in a hurry in the morning, you put your pants on. The first time you sit on the toilet, you go to pull your pants down and they're stuck because your pants have stuck to your gel. And you know what? It feels a lot like, well, you use your imagination. It's really not a great feeling when you do that. So I like it at night because then you can let your leg dry.
Pants dry.
So that's I will say that's my probably number one.
That way nothing's getting stuck to your leg.
No. And that's, and yes. So go ahead. What's your favorite, ladies? Anybody?
My my go-to in general, because, well, you know yourself, every woman is so different, and we talk about during the appointment what would suit them. So we'd have this whole discussion, but I find a lot of my patients and me myself go with the patch. This one is you change it twice a week, and here it is there.
So an estradiol alone patch. Right,
yeah, estradiol on its own. And then you tend to put that on maybe your lower tummy, your upper thigh, lower back, or your buttock. I've tried putting it on my lower back, and it's like when you get a bit of tape and it folds over on itself. That happens to me every time I try it. So I always end up putting mine just on the lower part of my tummy. And I find that if you invest a minute just putting it on properly, so you make sure there's no moisturizer or lotion on there, because you want really dry skin, put it on and then put your hand over it for a minute, because all the estrogen is in the adhesive. And so you need to get a really good bond to your skin, and the heat of your hand will warm up the adhesive and get a really good bond. And then it should stay on, you know, through your swimming or your showering or bathing or whatever. And then you change it twice a week. It's got about 3.5 to 4 days worth of medicine in it. Another great option I find for women who have migraines that are sensitive to estrogen, because you really are getting that nice steady state.
Yep.
I find that if I use the once a week patch, they tend to complain of, women will say they get migraines towards the end of the week. Yeah. So I definitely don't feel like you get that steady state with the once a week patch. How about you, Rebecca? Oh.
I just want to say, I had a patient with the once a week patch that she came in and she was having some irritation and redness from that patch. And I had her lift up. I'm like, well, show me I wanted to see the area. And that patch was like,
it's huge.
Big.
It's like a frisbee.
It's like your face.
I mean, what is that? Like 3 inches across?
Yeah.
I mean, it was really big. And I was like,
there's no hiding that bad,
I was like,
bad boy.
Rip that thing off. I'm like, that looks, I mean, it's like 5 times the size of your belly button. I'm like, that's too big. And apparently some of the brands are that big. And then some of the brands of the once a week are smaller, but you don't know until you get home.
You don't.
And, you know, what about side effects at all? What have you had patients say as far as side effects, Rebecca, with the patches?
I've had them usually 2 things, and my go-to is typically the patch or the gel, depending on the patient. I have most of my patients try the patch first. And then I can talk about the ring. I have that here too. But most of the side effects that I hear is either they get that like nausea and maybe the start of a migraine at first. So I feel like they're getting this like release of estrogen. And especially if they're postmenopausal and haven't seen estrogen for a while, it's almost like the receptors are like, oh my gosh, we're so excited. Like, here it comes, girls, you know?
Yeah.
And then, or they're getting it at the end before they get their new patch on, they're starting to get a little low. And so sometimes, you know, every 3 days is a little bit better, or sometimes I'll have them use the gel to supplement when they're growing low. But I will tell you too that, you know, that I agree with Aoife on this, that patch, at least a twice a week one, if you put that thing on, it's like waxing when you take that thing off.
Yeah.
Oh, that's a good analogy.
Yeah. I mean, I usually have to brace. I'm like, all right, here we go.
Yeah.
And I've like sauna, hot tub, swim, you know, and I know I don't know if you guys have heard from your patients, like, you know, and I actually think I had a pharmacist tell one of my patients, like, you can't go in the hot tub with this and you can't go swimming with this. It's going to release all the estrogen at once. And I'm like,
all the water sports, all the things.
Anything. Yeah.
Yeah. Every now and then I'll have patients get the irritation, the redness and the itching, and very rarely hives, very, very, very rarely hives.
Yep.
And that's, you know, usually when we'll switch to something else. But I think, you know, I tell women all the time, it doesn't, you know, we love transdermal, but it doesn't matter what you do. All that matters is can you remember to do?
Yeah.
So that's what you got to pick. What's going to work for your life.
Yep.
Yeah.
And
can I give a tip for the just in case anyone is listening who gets that little rash when they're, you know, a day or two into the patch? The over-the-counter Flonase or fluticasone, you can buy that over-the-counter, spray the skin that you're going to put the patch on with one spray, let it air dry for a minute, and then put your patch on. And that works really well for a lot of women.
That's a great tip.
Yeah. It's a great
tip. We love our tips.
Yeah.
Yes. Again, one brain, 3 people.
One really good brain.
Let's talk about the other kind of options that aren't oral, and then we could do oral. So maybe the ring.
Yeah, she's got a ring in her hand.
Yeah.
I do. This is called the Fem ring, not to be confused with the E string, which is just for vaginal, and we'll do that in another podcast. But this is the Fem ring. This is almost like, if anybody remembers the Nuva ring.
Yeah.
Right? That's my brain fog right there, ladies. And so I know those of you who can't see it who are listening to the podcast. Yes, the crickets. Thank you. That was awesome. That was the brain fog because I couldn't remember Nuva ring. But those of you that are watching us like on YouTube, or you'll be able to see this. So this is the Fem ring, and you just squeeze this little bad boy and then you insert it intravaginally. And that stays for 3 months. And it's really great. It slowly releases a certain amount of estrogen every single day. And then after 3 months, you take it out. If it comes out, you wash it, you put it back in. For those with male partners, some can't feel it, some can and like it. So have a great time. It's fine. What I've heard with this, not with everyone, is it can lose some of its efficacy before you're due to change it. So I would keep maybe some gel on hand, and, you know, in case that happens before you get your refill, then you can either put a patch on or you can add some gel if you find that that's happening before you get your ring to change. I'm talking like maybe a week or two before. So
what about pricing, Rebbecca, for that?
Yeah. So this thing's extremely expensive. I think, Christine, you were saying it was covered by
TRICARE
insurance.
TRICARE has it on formulary.
So random.
It's so random.
They have all the expensive stuff on formulary.
It's very expensive to get this through the pharmacy. There is a different pharmacy, transition pharmacy, about $180 for 3 months.
Yeah.
So I think that's really, really reasonable. So let your clinician know transition pharmacy.
Yeah. And if it's not covered by your insurance, it's $600. So
it's insane.
That's $200 a month. And then transitions pharmacy, $180. So definitely better, but we shouldn't have to be paying for this, but
No,
that's another story.
correct.
Yeah.
Correct.
And then the other patch that I have here is circular compared to the little postage stamp one that Aoife showed. This is a combi patch. And so this is estradiol and norethindrone acetate. This is the combi patch. Comes in 2 different doses, a 0.14 and a 0. Let me see. Let me remember that for correct in a minute. It's a 0.14 milligram progesterone or a 0.25 milligram progesterone. Most women, unless they're, I'm going to just throw this out, 5 years menopausal on the 0.14 milligram will usually have unscheduled bleeding with it. So if I prescribe it, which sometimes I will, the 0.25 milligrams, but it's the synthetic progestogen, norethindrone acetate, as compared to the progesterone, which is more like what your ovaries were producing. But it is an option for you. We just prefer progesterone because there hasn't been any associated increased risk of breast cancer with progesterone as compared to the synthetic progestogens, but they are not evil. And sometimes we do need to use them, and it is okay to use them. You still need to keep getting your mammograms. But it's an option if you just want one patch and be one and done and change it twice a week.
Well,
and you can use those levels, right?
Yeah.
Of estradiol if
you've brought us on to the combined therapy then with that, Christine. That's great.
Yeah.
So the combined estrogen and progesterone therapy, which we use for women who do have a uterus. That progesterone, that progestin in that combi patch, I have very few women that will control their bleeding. I get so many complaints of vaginal bleeding on that combi patch. So if you're on a combi patch at home and it's working for you and you're not having vaginal bleeding, that is wonderful. Yeah, but I just have not had great.
Drop us a line.
Yeah, they have to either have an ablation. The ablated uteruses do really well on it, or like 5+ years menopausal on the higher dose. Otherwise, I see so many people on the lower dose progestogen, and they do not do well. And we use that norethindrone acetate for women who, orally for women who can't take progesterone, and the 5 milligrams, they do not bleed at all. It's the low dose in that patch.
Yeah.
Which is interesting because there's not an oral equivalent to that, which would be nice. I had someone reach out to me, ask me about that. I know, and I was like, I know it's not. You've got the 5 or half of 5.
Yeah,
that's it.
Let's talk more about the oral options for progestogens then, which includes progesterone, natural micronized progesterone. Yeah, and then the synthetic progestins. We could talk about those for a minute.
Yes. Yeah. Do you want me? You probably have the micronized progesterone. So at least you can show people, but the micronized progesterone is, that bioidentical, body identical, equal to what your ovaries make, works on the GABA receptors of the brain, helps to help you sleep. It can decrease your anxiety, and then it protects your uterus from the estrogen, causing that lining to grow. Comes in a 100 or 200. I believe most of the data that I have read that usually anything over 300, you're not getting much more of a benefit out of, maybe more just of your sedation and things like that. I do have some that do need 300, and they do really well with sleep and anxiety and not having any side effects, but it can come with some of those side effects like water retention, some reflux, some bloating. A lot of times that will go away over time for women, sometimes some gas as well. But there is a percentage of women that don't do well on it. And so then we need to move on to the synthetic ones, or instead of taking it orally, there are some other ways that we will do it. We'll do it intravaginally as well, off label. So,
and the women who love the micronized progesterone really love the micronized progesterone.
Really love it.
They? Like we talked about that in a previous episode, how that micronized progesterone gets converted to allopregnanolone in the brain, which acts
Mm-hmm.
on the GABA receptors, which stimulates rest and relaxation. And women will say it's really helped with their anxiety and it's really helped them get to sleep at night.
Yes.
And then there's some other women who do not love it at all, who are really
Right. They
progesterone
feel
sensitive.
terrible. Yep.
Mhm.
Yep.
And if you have a peanut allergy, you cannot be
Yes.
on the progesterone that we get in the pharmacy. That's when we have to compound it for you at a compounding pharmacy, because it is slung. I always say slung in peanut oil.
Yep.
Yeah.
Yep.
So that progesterone. And the other thing I tell women is, you know, sometimes women will walk away from a provider with a whole stack of hormones. Occasionally they get really lucky and they're like, here's some estrogen, here's some progesterone, here's some testosterone. Not that very often. But then nobody tells them how to take it. And that progesterone you need to take before you go to bed, because the reason why we love it is it makes you sleepy. It's sedating.
Yes.
So many women are like, this progesterone, I've been so tired since I started to take it. And I'm like, when are you taking it? They're like, in the morning. I'm like, no, take it at night so you get those sleep benefits. And I even tell women, don't take it before you're going to watch a movie with your family, because you're going to be crashed out on the couch. It won't take long for you to feel really sleepy and fall asleep.
Yeah.
Yeah. Or their providers will start them on too high of a dose. And these poor women are like knocking into the walls and, passing out and ending up in the ER because they started on like 200 right out the bat, So at least for me, I like one hormone at a time, and I like a low and slow.
Yeah.
And I just,
and if anyone's having problems with it orally, my next suggestion is to insert it vaginally or rectally at bedtime.
Yep.
And it's that same capsule, the same one you were taking by mouth. You can pop it into the vagina or the rectum and see if that suits you. Because for a lot of women, if they're, I've had a few patients recently tell me it really what makes them feel wired for some reason.
I know. I have a couple, and they actually take it in the morning instead.
Yeah. And so
I know.
you have to try different things, right? So my first thing is try it vaginally.
They're all little.
If that doesn't work, then I'll say try it in the morning. And if that doesn't work, then I know we need to change it.
Yep.
Yeah.
We're all little special unicorns. I'm telling you. I tell every patient that. I'm going to tell you what it's supposed to do.
Yeah.
And then you're going to tell me what it actually does to you.
I say you're like a little Ferrari, with this beautiful engine, and we're just tinkering under the hood, and we're trying to find exactly what works for you.
Exactly. I like that.
And other progestogens, I think maybe we kind of talked about them. Norethindrone, or the mini pills, the pops, the ones that most women are familiar with that they have when they're breastfeeding, or they can't take estrogen and they do a progestin-only birth control. So that norethindrone is an option. The norethindrone acetate, which a lot of women, if you go into your GYN and you're having really heavy bleeding, will give you 5 milligrams of norethindrone acetate to shut your bleeding down. So some women may be familiar with that. And then Slind is really good. We like Slind, drospirenone, and people are familiar with that for being in Yaz birth control, and a lot less bleeding on drospirenone than on the norethindrone. And then, of course, the IUD as well. And then there is a gel called quinone, but I haven't heard very good. People say it's messy and oily, but there is a gel. I've never prescribed it.
Me neither.
I haven't either.
With the progestins, a lot of them are from kind of testosterone based. So if you have a woman who already has had some excess testosterone issues throughout her life, if you have polycystic ovarian syndrome, for instance, then those women tend to love the drospirenone, the Slind, because it's not from a testosterone kind of base.
That's a good point.
And I can't think of anything else helpful, really. The IUD, like the Mirena, the Kyleena, the Loletta, we do use them as part of menopausal hormone therapy, but they're another thing that aren't FDA approved for use in menopausal hormone therapy. But the Mirena is in Europe.
Yep.
So we use it off
in
label.
Europe.
So we use it off label here. Yeah.
We use it off label.
And the good thing I mentioned about that IUD is that you can add progesterone to the IUD, because the IUD is just to protect the uterus. So you're not going to get sleep benefits out of it. So I hear, sometimes patients will come and say, I really want that progesterone, but nobody will give it to me. You can use progesterone with a progestin IUD for those sleep benefits.
Great point.
And the other synthetic progestins don't do that, if we think about that, right? Because all of those women on those pops would be sleeping.
Yeah. And I'll say one more thing about those progestins. Sorry, if we're moving on. Okay, so the mental gymnastics of this drives me crazy. So I would love to bring it up. Doctors are terrified of giving women hormone therapy for menopausal symptoms because of the progestins. They say the progestin is what increases your risk of breast cancer. Okay. Now, if we could just please break that down, because the progestins that we are using are the exact same progestins that your doctor is pumping you full of in the birth control pill.
Exactly.
Birth control pill is very safe. It's a wonderful medication. It does have some risks and benefits, just like other medications. It's been life-changing for women on this planet. We've been able to have careers and put off having children, not have children. It's been incredible. But these are the same progestins that doctors then become terrified of once you call it hormone therapy. How did they convince us of this? How do you square that circle?
Have we even studied all of the progestogens? We've only studied medroxyprogesterone in the WHI. So, we don't have studies on every single other progestogen.
There's
We're just
a bunch of
extrapolating, right?
From France, from the E3 study. Yeah. And there's a slightly increased incidence of breast cancer. It may have to do with the progestin causing the breast tissue become a little more dense and it being harder.
So it's harder
on a mammogram. Yeah. Right. But really low risk, like the same as being overweight or sedentary, having a big glass of wine every night. Yeah. So, but that risk, those are the same progestins that you've been taking all these years in the birth control pill, and no one has mentioned breast cancer to you. So nothing magically happens when you come off the pill and go on to your menopausal hormone therapy. If it's a synthetic progestin, it's the same medication. I just don't understand how we've all been so brainwashed to not use our brains and think that through, Yeah,
you're right.
It's pretty funny.
So I had to get that off my chest. Sorry.
Nope, that's
very
a great
frustrating.
Point.
I find it very
it's a really great point.
So we don't need to be scared of these things. I'm a primary care doctor. I've been in medicine for 30 years, and these are the safest medicines I've ever prescribed. Safe. I've never had a patient end up in the emergency room with these medicines. I have when I've put them on statins or blood pressure medications or diabetes medications. I've had patients end up in the emergency room with side effects. Never once, touch wood, from a hormone. So we have to get past this fear. Okay, I'll get off the soapbox now.
No, it was a good soapbox.
We enjoyed your soapbox.
Talk about testosterone.
It was really good. Do we want to say anything about basodoxifene at all?
Oh, basodoxifene. Yes, Duvie. I love it.
Duvie.
I love it too.
Yes, I do. I haven't used it a whole lot, so you ladies may have better experience with it. I actually took a patient wanted off of that. And to go on.
Oh, really?
Whoever the provider was, just I guess was comfortable with it, and so put her on that, not for any any reason at all.
Let's tell our listeners what it is.
Yeah. So Basodox is a selective estrogen receptor modulator, or a SERM, estrogen agonist. It has. So combined with conjugated equine estrogen to form a tissue-selective estrogen complex.
Yeah.
Does that sound smart?
Sounds really smart, and nobody will know what we're saying. So
it's supposed.
It's made up of two medicines, right? Duvie.
Yes.
Yeah.
Right. Yes.
Right. The conjugated equine estrogen.
The conjugated equine estrogen and the basodoxifene. So and that works on that uterus so that it doesn't grow the uterine lining because of the conjugated equine estrogen, right? It makes the uterine lining thick, and the basodoxifene keeps that lining thin.
Yeah. We
Did I
didn't
say it
talk
right?
about combined equine estrogen when we were back doing our first.
No,
Doing
but
our
we haven't
pills.
talked about
Talking about
orals yet.
estrogen.
Yep.
Oh, yeah.
Yeah. And so Duave, the other reason why we like it is that there's no stimulation to the breast tissue
Right.
and
So no
you don't need a
progesterone,
progesterone with
progestin.
it. There's not stimulation to the uterine lining. So you don't need a progestogen with that. We like it for women who are concerned about breast cancer. Some women, they may have a BRCA, they may be BRCA1, BRCA2, maybe they have a family history, neither of which are contraindications for being on hormone therapy, but this makes them feel more comfortable because there's no stimulation to that tissue.
We might need to explain the combined equine estrogen then. So that's from pregnant mare's urine. The drug name is Premarin, pregnant mare's and urine. Yeah. So Premarin. And that is a big concoction of different estrogens. There's I think there's even a bit of testosterone in there. There's some progestins in there. It's a big concoction of stuff. But it turns out
synthetic.
And it's
synthetic.
And it's synthetic as in, it's from pregnant mare's urine, but it's put together
pretty
in the
natural,
lab, I suppose, into a tablet.
Correct.
Yeah. So that was studied in the Women's Health Initiative 20 years ago. And when they looked at women who were taking the estrogen on its own, so without any progestin, synthetic progestin, those women actually had a decreased incidence of breast cancer. It seemed to be really protective of breast tissue. What it seems to do is cause something called apoptosis of abnormal cells. So if a cell is growing and it's going through quality control and they pick up on it, the combined equine estrogen can help kill that cell. And then, so actually we know that is good for women who have an increased risk of breast cancer, right? Yeah. It can actually
even, and I think the data was even more so than the estradiol, if I remember correctly, right? Or maybe that was it was even more so then.
Definitely, yeah. I don't even know if we can say that estradiol definitely decreases your risk, but it doesn't increase your risk. Yeah, yeah.
Right.
So then
we extrapolate that all the time, but yes, you are correct.
Yeah. Yep. And then the basidoxavine is not licensed for use on its own over here. They only use it in that mixture pill, the Duave. And that's almost like tamoxifen, right? Same family.
Serum.
Navista.
Yeah. Yep. And so really good for your bones, really good for the lining of the uterus, and really good for the breast. So you've got this double, it's like a booster button. Which should be really protective for the breast. Yeah. And there's a study going on at the moment called the PROMISE study. And it's in women who have DCIS of the breast, which is not breast cancer. It's like pre-cancer. And they're giving women Duave for 5 or 6 weeks before their surgery. And they're looking at, the biopsy results from before the medicine. And then they look at the tissue again after the surgery. And so I think there might be some really exciting results from that study. I can't wait to hear.
Yeah, I am too.
Yeah. How hopeful for women maybe who've had breast cancer. And instead of saying to them, okay, we want you to be on tamoxifen for 5 years or an aromatase inhibitor, we say, here's your Duave. It's got estrogen in it, so you don't get all the side effects. It's breast protective, and it's got a sister of tamoxifen in it, which is doing that work.
That'll be really nice.
I know. I can't wait for that day.
Oh, that'd be fantastic.
I know.
And then we don't prescribe very often the oral estradiol or the synthetic, Premarin, but it's, I think we villainize the orals, but not,
a little too
we
much,
didn't need to, there are women that we will put oral estradiol. I think one of the things that's just important to know is that baseline risk for a woman between the ages of 50 to 59, there are 5 cases of having a blood clot for every 1,000 women. And then when we add, oral estrogen only over 5 years, it's 1.5 more cases. When we combine oral estrogen with a synthetic progestin, then it's five more cases. So a total, of 10 women out of 1,000. And so, I think, we try to avoid risk when we can, but the risk of being on oral estrogen for blood clots increases for the first 6 to 12 months and then goes back down to baseline. I like it for women who have high cholesterol, trying to get their LDLs down. I find it to be helpful to get their LDLs down. But I do know that their sex hormone binding globulin tends to go up. And if it's more than 170 and we're trying to put you on testosterone, then you won't get the same benefits because all the hormones are just going to bind up and you're not going to have any free and available to use. But there's some women who just want to take oral. And there are some combination, there is a combination pill that is, estradiol with progesterone, and women like that as well. And so again, I think it depends on what works for your life. And if you're someone who's healthy and doesn't have high cholesterol and you're not worried about a blood clot, you've been on birth control pills, you've been pregnant without any problems, and you want to be on oral, then do your thing.
Yeah.
Yep. I think as long as, those contraindications, high blood pressure, things like that, thyroid, because those can interfere, and sometimes oral estrogen, synthetic and non, I have found can increase the blood pressure in some women, even those that haven't had hypertension, and then obviously those that do have hypertension. So we're careful with that. Thyroid, just because it can bind the thyroid globulin and can interfere with that. So those women,
you need more thyroid hormone. You need to adjust.
Yep.
Sometimes with oral estrogen, a lot of it gets converted to estrone, which is more inflammatory. Estradiol is quite anti-inflammatory. So
it's another good point.
Yeah, and also can increase kind of gallbladder disease, like gallstones.
Right.
So I would say negatives for the old oral estrogen would be you get your increased estrone. It competes with your thyroid medication if you're taking that. It can cause gallstones, can increase your clot risk, and it increases your sex hormone binding globulin, which can decrease your testosterone and your libido. But like you said, if you're a healthy woman and you don't have any issues going on, you're probably going to be very safe taking oral estrogen.
Yep. Yeah, I agree. I think you have some of those patients, or at least I do, where, they're just like, I don't want any risk. I want to decrease any risk. And then that's where we're just like, listen, we have a plethora of transdermal options.
Yeah.
That's fine too.
So person dependent.
One transdermal option we didn't talk about was the spray that you spray on your forearm, 1 to 3 sprays daily. Some women, I've had a couple patients on it, and I don't know, they just decided they didn't like it. I don't know why they didn't like the spray on their arm, and we just would switch. We just wound up switching them.
Yeah. Insurance.
And that's a nice one for timed.
Insurance can be a bit tricky as well with the Evamist.
Yep. And sometimes the gel too. Depending.
Yes.
But those are both the gel and the spray, I find, are so nice for timed dosing in those patients. Like you were saying, Christine, they have, more flashes at night or during the day, or they're doing great on their patch. They can't go up to their next dose because it's too much, but they're still having flashes at night. Then a gel or a spray is nice to add. Let's add a little spray at night and you're good to go.
Yep. And I think the other thing that sometimes I will see is this, speaking more to the clinicians, confusion about that patch. And so just remember that the dose on the patch times 2 is what it's equal to in oral estrogen. And so if you're over 1 milligram of oral estrogen, which is 0.075 patch would be, your uterus needs more progesterone. You need the 200 milligrams. You definitely need the 5 milligrams of a norethindrone acetate, just to make sure you're protecting that lining and keeping the woman from bleeding. So, and, you know, gel and oral are equal to each other, but that patch, you know, and women get confused too when we switch them from gel to patches, because they think we're dropping their dose, but we're actually not.
Yeah.
Yep. And you can absorb it a little differently too. You might not be absorbing the patch the same as you do the gel or the spray. So sometimes we may have to still adjust even though we think it's the same. So
yeah. We may have to skip testosterone and give that its
Yeah,
own
I think we should do
episode.
its
I
own
think it
thing.
needs its own
Yeah.
episode. It deserves its own. It's so
Yeah.
beautiful.
Do you want to? You're going to do our wrap up since Aoife
Yes.
I'll
actually
do our
takes
wrap
all of
up.
our notes.
Yeah.
Yeah, you have.
She's the secretary.
I can't find her.
I've
the nerd
nominated you
up the front.
secretary.
Okay, so let's pull this all together with some takeaway tips. So first of all, menopausal hormone therapy is so safe. Please don't be scared of it. And hopefully by listening to our podcast, you are becoming more comfortable thinking about it and talking about it. We also want to get rid of the myth that it's only for severe symptoms. You know, we need it for our bones, our brain, all our organs, and to stay in good health. And there was another one I thought of there. If you want to go on a certain type of hormone therapy and you're finding that your insurance is not covering it, we know some tips for that. So make sure you check GoodRx website to see if there's a coupon for that. Mark Cuban's Cost Plus website is very helpful, especially for vaginal estrogen cream. It's so much cheaper there than a lot of insurances. And then there's the HRT Club, which I think is part of Transitions Pharmacy. So you can join that for $99 a year, I think, and then you can order your hormones through there. And for a lot of women, because they're on maybe the gel or something that's not covered by their insurance, that works out much cheaper than the big co-pays from their pharmacy.
And Amazon.
Oh,
Amazon right
Thank
now
you.
is the
I was gonna
lowest
say
in
that.
vaginal estrogen cream.
Is it? Oh, that's good. I didn't know. All right, our midlife tribe. Remember, you're not alone in this journey. Be informed, be empowered, and keep thriving through midlife. Until next time, stay fabulous.